Hello everyone, I'm Dr. Sambhav Shah, and today I'll be discussing a video on the extraforaminal full endoscopic discectomy at a L5-S1 level. The patient was a 45-year-old female with significant left leg pain since the past 5 days. The pain was there since around a month but had increased significantly in the last 5 days. On examination, she had weakness in the left EHL and also in the left ankle dorsiflexion, which was grade 4 out of 5. The patient was in such significant pain that she had developed a list and she was not able to even bear weight on the left leg. On the MRI scan, the patient had a left-sided extruded disc which was compressing the exiting L5 nerve at the L5-S1 level. At this level, generally in the extraforaminal region, is the dorsal root ganglion. And the dorsal root ganglion is a very sensitive structure, which explains why the patient had such significant pain. The X-ray did not show any instability on the AP or lateral view. As you can appreciate in the AP view that the patient has a wide interlaminar window. Now, we discussed with the patients all options. However, because she was in significant pain, she decided to undergo a surgery. Now, on the MRI scan, as you see that this disc is lying underneath the facet in the extraforaminal region. Conventional approaches, if I have to go from the back, would mean that I may have to resect a lot of the facet joint, number one. Number two, this may, if you don't do endoscopic surgery, you may even think of doing a fusion, as you would have to remove the complete facet in order to get the piece of the disc. Number three, if you're doing endoscopy, we could do an interlaminar endoscopy. However, that would also entail a remove of significant amount of the facet. Or we would have to take an approach from the right side, burr the lamina, go over the top into the left-sided foramen and try and get that piece out. But that also would be quite difficult to do. However, if you see her X-ray closely, you can see that the iliac crest is a low-lying iliac crest. The iliac crest is not high, which you see in normal cases, which is usually at the L4-5 level. However, in her case, the iliac crest is much lower, and it is possible to use the transforaminal approach, where you come from the side directly into the foramen and the extraforaminal region and remove this piece of the disc. One more option to do a transforaminal L5-S1 level is to burr the iliac crest. That means you make a window in the iliac crest and then approach the transforaminal region. However, in this case, since the iliac crest is low, we would not have to go transiliac. In this case, since we want to dock in the extraforaminal region, my entry point will be steeper than normal. However, on the preoperative MRI, facetal hypertrophy must be checked because sometimes you may have to burr out a little bit of the facet to gain entry. However, in this case, since it's extraforaminal, I will take an entry point roughly 8 centimeters from the midline. You can also get a full volume MRI done, which can aid you in deciding your entry point. It gives you an approximate area of the skin incision. Transforaminal surgeries usually we do under local anesthesia. However, in this case, the patient was under GA. And the reason for this is that normally we square the vertebra and we mark the center of the disc. However, in cases like extraforaminal disc, I usually dock my camera first at the lower pedicle and then I move the scope superiorly. Also, the skin marking in AP will be slightly different than your conventional transforaminal cases, as over here I will have to mark the skin entry point in AP in such a way that the iliac crest does not come in my way. The blue lines here indicate the disc space. However, when you see the red line, that is the way my trajectory will be in order to keep away from the iliac crest. So normally we take the trajectory in the center of the disc. However, as I mentioned earlier, that I want to dock my endoscope at the superior border of the inferior pedicle. Hence, in this situation, my trajectory will be different, where I am first docking my needle at the superior border of the inferior pedicle. After I put my cannula and my endoscope there, I will start the surgery from there and then I will move upwards. Then we will move the C-arm in the lateral position, and I usually mark the tip of the spinous process and the posterior border of the facet joint. We have to always remember that in any transforaminal surgery, our entry point should never be anterior to the facet joints. In this case, since I want a steeper trajectory as I want to go in the extraforaminal zone and not centrally, I will mark my entry point at the tip of the spinous process. If it coincides between the 8 to 10 centimeter zone, then from the midline, then I will take my entry point over here. So our first line was marked in AP, our second line is marked in lateral, and the intersection of that lines will be our entry point. Then the needle is inserted after giving some local anesthesia, and once the needle is docked at the superior border of the pedicle, the guide wire will be inserted, and then over that the dilator followed by the cannula and the endoscope. Now we are operating from the left side, so 9 o'clock is the head end and 12 o'clock will be the dorsal area. The 3 o'clock is the leg end. Now where the leg end is, that is going to be the superior part of the S1 pedicle. The yellowish area what you see is the fat, and that's where I expect my disc space to be. At around 7 o'clock position will be the L5 exiting nerve. Now, the first thing is that we need to confirm all our anatomical landmarks. So, a RF probe is important to feel. And here, when I am touching it, I can feel that this is a bony area. So, this is my superior facet. And when I'm going inferiorly, I can feel that it is going down into the pedicle. The beauty about extraforaminal scope is that it's not a rigid system. Normally, in transforaminal endoscopy, we dock the scope into the foramen. So it's a rigid system, but in extraforaminal, it's flexible and hence it's even more difficult to execute this surgery. Now I'm clearing out some soft tissue which is there in front of me, and while probing with the RF probe, I can see some whitish material over there, which most likely is the disc, which has extruded out into the extraforaminal space. On probing it further with the RF, I am just trying to clear out the disc and trying to milk it out actually and clearing the surrounding soft tissue around it. It's very important to free it from all sides, and automatically you see that the disc just comes out when you create space. So any there it is. That's the disc just completely coming out once you create space, and then we need to remove that fragment. Always remember that whenever you're catching something, you have to see the tip of your instruments, otherwise it can prove very dangerous. The L5 exiting nerve is right here, and you can easily pull it out if you are not doing it under vision. Once this fragment is removed, even with the scope, I could feel that the tension of the nerve is much easier. As I mentioned earlier, that I'm doing this under GA, and in these patients, when you're working around the dorsal root ganglion, they are very sensitive, and the patients are in a lot of pain. And because I take such an entry point, I feel that I can do it under GA much more safer because I'm coming from inferior to superior. And manipulation of the nerve also causes a lot of pain. And because the patient is in GA, I am at a much better place to execute this surgery. However, yes, there is a chance of you causing further deficit, but if the pressure on the cannula is maintained and not being aggressive, then we can easily execute the surgery in GA. Now you see here, I can see one more fragment right underneath the nerve. So it is important to look for fragments as they all can be under the nerve in this extraforaminal region. I am using a nerve hook to try and remove that fragment as well. However, I was finding it quite tough to milk it out. The instruments we use in endoscopic surgery are similar to open surgery, however, they are longer in length and smaller in diameter. On trying to probe that fragment out, still I was causing a little bit of tension on the nerve, and I think it was I'll remove this nerve hook now and probably use a pen field to try and probe it further. Now with the pen field, as you see, we have been able to remove that piece of the disc again, and this was actually quite a big piece of disc which we removed. Now it was hiding under the nerve, and in a lot of circumstances, you tend to leave these pieces behind. You get so excited when the first piece you see comes out and you feel that the surgery is done. But however, always look for other fragments, especially in such cases. Now I'm going to further probe the area. Now this is exactly in the axilla of the L5 nerve. As you can see, I'm using my RF. I'm probing the area further. I do see now probably there is one more fragment over there, which is underneath the nerve root in the axilla of the nerve. So here we are working under the exiting L5 nerve root. We are using the nerve hook again to try and probe out the fragment. What you see in the middle of the screen is all the annular fibers. I have rotated my endoscope right now. So at 9 o'clock is the nerve root, at 12 o'clock is the superior part, but you are seeing it at an angle. Now I'm using my disc forceps and going into the disc space over there and the axillary region. Again, you have to be very careful when you're doing this. You can also use the C-arm to see how deep or how superiorly you are going. One more fragment has been, loose piece has been removed over here. In endoscopic surgery, because the magnification is quite a lot, sometimes you may feel, oh, have I touched the nerve? Have I torn the nerve? Because a lot of these smaller fragments, a lot of the part of the PLL, it all seems as if it's the same. It's a nerve. So initially you can get confused, but as and when you keep on doing these surgeries, you become more and more confident. For me, I would feel that L4-5 or L3-4 paracentral disc, where you have to just go into the disc space, should be your initial cases for for a transforaminal surgery. However, in once you are used to the transforaminal surgeries, then you can venture into extraforaminal cases. So here, as you can see, I can see a nice space. That space, the dark area which you see lying between 9 o'clock to 7 o'clock is where the disc was originally. My probe is also going in quite freely. However, on trying to mobilize a nerve further, in the center of this frame, you can see I do see one more fragment over there. Probably is a fragment, or probably is just some remnant of the annulus. So we'll have to probe it further and check whether we have not left any pieces behind. Because you will feel you've done a beautiful surgery, but the patient still has pain post-op, and it could be these loose fragments or another big fragment which could be hiding under the nerve. And as you see here, there is definitely a fragment which is hiding under the nerve there. And I'm using my tooth forceps to try and get that fragment out. And it was again quite a big piece of disc. So overall, we removed four pieces. We didn't have one huge piece, rather there were 4 to 5 fragmented pieces, and they were all quite big. And I think one more thing to note was that the overall retraction of my nerve also became much easier over here, and that is also a sign that my nerve root is free at the moment, and I don't see any more fragments coming in my way.